Welcome to Savage Minds. I'm your host, Julian Vigo. Today's guest is Charles LeBaron. For more than 28 years, Charles LeBaron worked as a medical epidemiologist at the Centers for Disease Control and Prevention, the CDC. While there, he was the author of more than 50 scientific studies published in peer-reviewed journals, including first or senior author papers in the New England Journal of Medicine and the Journal of the American Medical Association. He was a co-recipient of the CDC's Charles C. Shepard Science Award for Best Scientific Manuscript, published by CDC authors. A captain in the Commissioned Corps of the United States Public Health Service, he received the Meritorious Service Medal, as well as more than 10 other individual and unit commendation awards. A graduate of Princeton University and Harvard Medical School, he is board certified in both internal medicine and pediatrics, as well as the author of a previous nonfiction account of the first year of medical school. He currently lives in Atlanta, Georgia. I welcome Charles LeBaron to Savage Minds. I have written much about the opioid epidemic in the United States, which has been, as you know, until recently, either underreported or more likely completely ignored. I wanted to begin with the reasoning behind why you wrote this book, because a lot of people that are listening will be shocked by some of what you uncover in your research.
I basically stumbled into opioids accidentally by nearly dying. And I had staphylococcal meningitis, a infection of the lining of the brain that got into my vertebrae, collapsed my vertebrae, and then while my immune system was trying to save my life on that, some varicella zoster viruses took advantage of the situation and ulcerated about half of my body. So I was definitely in some, what most people consider severe pain, and the antibiotics and antivirals saved my life, but the opioids in this context saved my mind because each millisecond of the level of pain I was in was just sort of disastrous mentally. And the only thing that could take the edge off didn't eliminate the pain, but the only thing that could reduce the distress were high doses of opioids. So that gave me a familiarity with the values of opioids, which I hadn't really ever had before. I ended up with about 6 months of IV antibiotics and about an equivalent amount of time on opioids. And by that time, it was outpatient. And I became very aware of how restrictions on opioids for legitimate purposes had created a paradoxical effect where people who couldn't obtain them for legit reasons were almost inevitably displaced into the illegal system. And that had the paradoxical effect of increasing overdoses, where the objective on the restriction of prescription opioids was to reduce overdoses. And out of that experience, I said, maybe I should look a little harder into this. And that's what initiated my interest in the book.
When did opioids become part of, let's say, the medical profession's prescription writing practice for patients outside of hospital settings?
Well, of course, opioids have been known since the millennia and have been available for use and been misused for addiction for centuries. What turned things around in the United States, at least, was in the late 90s and the beginning of the 2000s. A number of drug companies, there are a number that are very famous now, the Sacklers with Purdue, but there were a bunch of others, saw opportunities to make money, which they basically have to do to meet their stockholders' expectations. by promoting opioids. And this was in the context of a sort of a curious campaign which entered into medicine that nobody should be in pain. Now, no one can argue that people should be in pain, but trying to eliminate pain is like trying to eliminate sorrow or distress or anything else that's part of life. And they developed, well promoted by the drug companies, the concept of a pain scale in which everybody who went into any medical environment was asked what was their level of pain. And the notion was that if they had a pain level above zero, you should give them something for the pain. And needless to say, that sort of made an open season on opioids. And more and more and more opioids were being taken for to reduce everybody's pain level to zero. And as a consequence, ultimately the United States was consuming, and to some extent still does, 80% of the world's opioids, prescription opioids, when we were only about 5% of the population. At the same time as this increased use of prescription opioids, there was an increased level of overdoses, both fatal and near fatal, which finally drew the attention of the public health authorities.
In the United States, although we know of opioids since, as you mentioned, the turn of the century, and the word itself, opioid, is derivative of one of the substances that used to be used once upon a time for pain treatment, aside from illicit adventures in hallucination and whatnot. There's been, of course, a deafening silence on any kind of addiction, even pre this millennium. And there's a paradox for me personally. My father was a dental surgeon, a periodontist. And at a very young age, unbeknownst to us, because we were children, my parents developed a Vicodin addiction. So for us in the 70s, we were often sent to the pharmacy to pick up Vicodin prescriptions. We were drug runners as children. And it wasn't until I was much older that I understood that my father was severely addicted to Vicodin. And as a health practitioner, of course, there was a blind eye turned to that. It makes me think of Cider House Rules. I don't know if you've read the John Irvine novel, but clearly he was basing this partly on reality of an early 20th century New England physician who himself was an addict to an anesthesia. I wonder to what degree the AMA or other medical associations have been alerted to some of the problems of opioid addiction before mainstream media started to clutch onto this narrative.
Well, I think you have to look at it to some extent from a sociologic standpoint. And now my understanding is that, Julian, you're an anthropologist, so I'm now starting to tread into your territory, and please correct me when I start to put my foot in my mouth.
I'll prescribe Percocet for each mistake. No, I'm joking.
Okay, well, why not? The in a sense, addiction fell into two categories sociologically. One was the good people who happened to use them from prescription and went to the drugstore and got them, and it was a little bit like alcoholism, sort of, regarded as a honorable addiction. And then there were the bad people who shot up heroin, and they had moral failings, those folks. And to a great extent, if they died, it was sort of Darwinian justice, and we were sort of better off without them when they shot up. So there was, in a sense, a bifurcation of the issues around opioid addiction, and I would say that your family's experience placed them in the sort of tolerable addiction, and then a whole bunch of people, often African American in the United States, who didn't have that kind of access, but did have plenty of access to heroin through illegal means. The bad things that happened to them were considered sort of undesirable, inconsequential in many ways. However, to the extent to which they were considered consequential at all, because they produced, as you might imagine, crime and other issues around the addiction, there was a war on drugs. Now, it wasn't a war on Percocet. It wasn't a war on Vicodin at that point. It was a war on the people who were using heroin. And it was sort of a war on the underclass for having their addiction. And it basically skyrocketed the amount of incarceration. But it wasn't your father was getting incarcerated. It was, and I'm not recommending you get incarcerated for that. But it was a whole other group of people who were filling up the prisons at the same time. So there's this combination that you're pointing out of silence in one area and then moralistic fervor in the other.
Oh, absolutely, because a lot of what happened with the drug wars in the States, it was contained to, as you mentioned, African American communities, Latino communities, and what were the big shows of the 80s? Miami Vice, right? I mean, we were a country obsessed with this kind of interior drug war, but it was very class and ethnic focused, let's put it that way. Skip to the last 20 years, and you see the photos. It's very hard to get beyond some of the photos of the couple in the front of the car overdosed and the child in the baby seat in the back asking for its bottle. And you're just like, and these are often not poor, definitely a lot of white Americans, right? That one must wonder if the PR machine has begun with major media, because this is no longer about the poor and disenfranchised, but it's about, it could be you. Right? So a lot of middle upper class Americans got caught in the opioid crisis. And as your book tells the story, including your professional experience of what you've seen and lived through, and then, as you just mentioned, your personal experience with opioids, one can quickly understand with some kind of autobiographical experience the derogating crack, cocaine, and of course heroin and all the quote unquote street drugs as bad, but all the ones that our doctor writes up as good. Therefore, bifurcating, as you said, who's a victim of the system, and then from the late 20th century, those who in fact were rather evil, as they were demonstrated in media representations. Now, I have to ask you about this first part of your book, because you begin in your foreword with a daunting statistic, and I'm going to read this for our listeners. You talk about the deaths from opioid overdoses as being, and I'm quoting you here, more than twice as many deaths as from breast cancer or prostate cancer or colon cancer, more than from automobiles and firearms combined. The cumulative overdose deaths this century now exceed the sum of all deaths for all the service members in all the wars of the United States history. Within a few years, the cumulative overdose death toll is projected to double. And your book goes on to tell a tale that most listeners will not believe and certainly will not be prepared for. And in brief, you relate the story of how this nationwide implementation that at first glance looks very reasonable, rational, the intervention by the CDC, had this kind of paradoxical effect of what you say, turbocharging the opioid epidemic. Could you describe what you mean by this? Because what I saw in your book is actually familiar to me in other paradigms, where the will to control something actually makes it far worse.
Well, I'd actually love to hear from you about those other paradigms because I'm kind of a little bit monothematic, and I can tell you about what I know on the opioid thing, and then any analogies you can bring to bear, I'd love to hear because it's you know, enlightening to me. But let me give you the basic sequence as I understood it, and I don't represent myself as being the final authority, and I would say sorry, this is under debate in some ways. But the basic sequence, continuing the sort of historical discussion that we had, is the use of opioids in medicine expanded enormously in the late 90s and 2000s under two impulses. One was the profit-making impulses of the companies, and then this sort of permissive notion that no one should ever experience pain. And it became obvious that more and more people were overdosing on prescription medications. It started taking over from heroin. And that those people who were overdosing on prescription medications were not Black people in the hood. These were middle class people. These are white people. And it suddenly became apparent to pretty much everybody that opioids not only have uses, but they have misuses and they have dangers, which is absolutely correct. And we had created, in effect, a legal addiction in America by this promotion of opioids for profit. Whereupon, quite correctly, the Centers for Disease Control, where I used to work, which basically addresses epidemics, said, we usually deal with infectious diseases epidemics, but this is killing many more people than most of our infectious diseases. It's time we stepped in. And they stepped in a way which, in a sense, is plausible, but just backfired completely. And the plausible element, plausibility and evidence-based are completely different issues. This was not evidence-based, but it was plausibility-based. Was, okay, if prescription medications and their misuse is causing lots of overdoses, the solution is simple. All we do is really crack down on prescription opioids. So we don't have this sort of freewheeling, prescribe it for everything, including a hangnail and anything that ails you. So they issued recommendations in 2016 as the prescription overdose rates went up to basically really crack down draconianly on who could get opioids, for how much they could get, for how long. And that was on the premise that that'll bring this whole overdose problem to a halt. Well, paradoxically, it exploded, the overdose problem. And the reason that it exploded is that there are two things that are very, very powerful motivators. One is pain, and the other is addiction. And if in each case, if you need opioids to deal with those, you're going to get them somehow. And what happened basically is when there is a restriction on prescription opioids, people who had pain and or addiction, and they could be combined, said, I gotta get my drugs, and they moved over into the illicit market, where it's far more dangerous. At the same time, a bunch of entrepreneurs located in Mexico saw an opportunity to expand their market share. So they got the precursors of a number of different opioids, but most importantly, fentanyl, from China, where they're cheap, assembled them basically into fentanyl in Mexico, and then transported to a gig economy into the United States. And fentanyl is much more powerful than Vicodin or Percocet or any of these things, number one. Number two, the Mexicans aren't assembling the cartels, the Sinaloa cartel or whatever cartel you want to mention, are not assembling under FDA inspection means. So the amount of fentanyl that was in any given pill or any given thing that someone was going to smoke or shoot up was not heavily regulated. So what happened was by converting from a sort of wide open prescription economy to an illicit economy, overdoses just exploded. And a little bit equivalent to what happens when you have prohibition with Al Capone and so forth. The difference, however, is this: no one ever, very few, ever died of their first shot of speakeasy gin. However, plenty of people have died by being passed a single pill at a party, frat party or sorority party, and told it was a happy pill, swallowed it, and that's the last thing that they ever did because of the uncontrolled elements. So the effect of this, in effect, prohibition on the use of legitimate use in many ways of pain control opioids was to displace people into a very, very dangerous illicit opioid environment, exploding overdoses to the point where now they're the major killer of adults between people between the age of 15 and 45, the number one killer.
Wow. And from the knowledge of this crisis, what was the government's reaction to, let's say, what was happening south of the border?
Well, there were two things. One thing that's interesting is that for reasons which aren't clear, and as an anthropologist, you'd be able to bring much more awareness on this. We rather than address a problem, we try and villainize people. And you can villainize in many ways the people who are the victims, or you can villainize the persons who have victimized them. But either way, it's a question of hatred and victimization and anger. So our perception became kind of twofold. The first was it's the Mexicans. And they're the problem. It isn't the fact that we have a whole bunch of addicts that aren't receiving treatment. It's the people who are supplying them. And there's legitimacy to it. These are criminal outfits. They're not nice people. But the idea became if we can go after the supply, the demand will take care of itself. Well, oddly enough, the war on drugs and the CDC's restriction on prescriptions had a similar characteristic. They both aimed at supply with no concern over demand. And the demand, if you're in pain, or the demand, if you're an addict, is very, very strong. And if all you do is try and go after, in this case, the Sinaloa cartel, keeping in mind that you can transport enough fentanyl basically in the spare tire compartment of a car to overdose the whole of Western United States. So it is very, very difficult to successfully interrupt supply. You can do it. You can arrest a lot of people. You can collect $1 million worth of fentanyl, and another $1 million is coming through at the same time you're having a TV show celebrating how much you did it. So unless you address the demand, really nothing is going to happen. That is useful. And that's what's, of course, continues to be the situation.
Well, what about the demand that was being fomented amongst the medical staff? Back in 2017, I researched this subject. I was really shocked that between 1996 and 2001, Purdue Pharma hosted more than 40 national, what they called pain management symposia at resorts across the US, to include Hawaii, inviting thousands of doctors, nurses, and pharmacists to take part. And you note in your book how they gave out, little cuddly bears, all kinds of gear. They also gave out several weeks of try this drug. Isn't this insane? I can't even believe we're talking like this, but they were doing this. And then they marketed oxycodone at the time, creating a future army of medical practitioners who would advocate for this drug. So they used the medical profession to be sort of their salespersons. And despite the belief that such enticements to luxurious retreats would not alter the doctor's prescription writing habits, of course. And the goal of these conferences was clear. It was to influence legions of doctors to overprescribe pain medication and to make the marketing and the promotion of drugs like OxyContin a commercial triumph and part of what became a public health tragedy. So I'm wondering, you mentioned these sessions also in your book where the Sackler family's Purdue Pharma entered into these kinds of promotions. What has been done by the government, any of the agencies, to investigate or curtail these kinds of operations that would pose a danger to even future drugs of this nature?
Well, the paradox is while we were simultaneously having doctors wined and dined in Hawaii, encouraged to give out OxyContin, uh, the guy on the corner who had maybe a little bit of some illicit drug was arrested and put in for a mandatory minimum of 5 years in the federal pen for having a quarter of a gram of something. So we had this bifurcated situation where, no surprise, the rich were getting rewarded and the poor were going to jail. Nothing new about that in American life in many ways. Where the question you're raising is what happened to the folks who did the profiteering? Well, to my knowledge, none of them have spent a day in jail. As a matter of fact, most of the folks who were really promoting it, the Sacklers or something, are still doing just fine economically, and they're doing a negotiation to only have to give up what 1 billion of their 10 billion family fortune or something, and that's the dilemma that they're in. When I worked in the federal penitentiary, the dilemmas that the relatively young people were in for having done much less opioid promotion than the Sacklers ever did was very different. You're talking about a savage situation in the negative sense as opposed to the tribal sense. That was a savage situation that they were put in. So there was once again this bifurcated view of opioids or outcomes in many ways. I would like to come back to CDC because my book is about CDC and mainly not because I never worked for the Sacklers. Yeah.
My thought is, though, in this new Trump administration, one of the things I just read last week that they are taking steps to ensure that the revolving door of, let's say, working at Big Pharma or vice versa, usually working in the government, approving certain drugs, and then somehow miraculously, after you're not elected back into office or you step down and you're on the board of a major big pharma company. So I was wondering if, in fact, the government in the past has discussed the possibility of some kind of oversight. In Canada, for instance, the government does not allow for these kinds of whining and dining fiascos. There are a lot of laws around this in many countries. So I was just wondering if on the table, at least, it was proposed some kind of resolution that would discourage the backdoor dealings between the private sector and healthcare practitioners.
Well, I think there are two issues. One is government regulatory agencies, and
Mm-hmm.
to some extent, that was this issue that's come up recently and has legitimacy. I'm not sure that quite as much application to opioids as to a bunch of other ultra expensive medications. But this, it's, I guess, more famous in some ways in the defense industry, where people go from procurement at the Pentagon over to Boeing, and in a sense, there's back and forth. I'm not sure that was as much the case for opioids. I think it was permissiveness on one side of the government, and at the same time is just wide open capitalistic promotion on the private side, and combined with the business about if you're doing heroin, it's awful. If you're doing Vicodin or OxyContin, it's okay. And that allowed the situation to proceed in this dual fashion.
Right. There were some examples, such as the former FDA Commissioner Scott Gottlieb, who moved to Pfizer after stepping down from that role, or the former HHS Secretary Alex Azar, who was previously also in a big pharma company. That happens. You're right. It's more common within even the tech. Now, big tech is doing it, but also the arms industry. It's just something that I noticed that the Trump administration claimed it was going to address. And last week, there seems to have been some steps towards that. Let's talk about the CDC. And the second part of your book that relates to your 28 years of disease control work at the CDC.
Yeah.
And you give an insightful narrative into your unique institutional experience and then the psychology therein that helped shape the agency's approach to opioids. And you wrote as if they were infectious pathogens whose transmission needed to be interrupted. Can you describe for our listeners what the CDC was doing, both at the beginning of this crisis and throughout, so that we might glean some kind of understanding of what the CDC's role was, for better or even for worse?
Yeah, thanks. I'd like to, in a sense, give the ending and then come back to the cause to some extent. The CDC implemented those draconian restrictions on prescription opioids, and for good reason in certain respects because of plausibility, but with very little evidence that they're going to work. And things then exploded because people were diverted off into the illicit market. Well, there's no dishonor in public health in doing things based on plausibility alone. Many times you have to work in a murky environment for which evidence is relatively lacking, and you do the best you can. In those situations, and the situation in the draconian restriction on prescriptions opioids, this sort of whiplash situation, gone from absolute free market to prohibition almost. There's no dishonor working on low evidence and plausibility. Well, the dishonor comes, in my view at least, is you don't watch what happens and modify your approach accordingly. The great attraction of draconian restriction on prescription opioids is they have a cost of exactly zero, to the government. If you decide you're going to treat the addicts, then you start getting into cost. If you decide only thing we're going to do is restrict people from getting prescription opioids, costs nothing. It's a great attraction to zero appropriation program. The difficulty is if you have a quadrupling of the outcome that you're trying to prevent, in this case, death. We're not talking about even feeling unhappy or something. We're talking about people dying. Winston Churchill had a little saying. He said, no matter how beautiful the strategy, you should occasionally consult the results. And the great difficulty in this situation was the results were not consulted in the sense of, okay, what are we doing that isn't working? And how can we change? And the thing that was, in a sense, perplexing for me in looking over the situation is why wasn't there an adjustment of strategy? Why wasn't there something? There's basically in the CDC recommendations essentially nothing about promotion of the antidote, and we have very cheap, easily accessible antidote, naloxone, Narcan. There's nothing about that. Here you have a poisoning situation, which is overdosing. You have an extremely effective remedy, and there's no mention of that. That's number one. Number two, there's no mention to any extent of treatment of people who are dependent. Nothing on the demand. Why was that? And to some extent, this is institutional psychoanalysis I'm doing with all the ambiguities that you might associate with it. And what became obvious to me, because this is the field in which I worked, is that the attitude of the people who were doing this had come out of the same environment that I worked in, which was infectious disease. And their approach was opioid is a pathogen. What we do when we're dealing with the pathogen is we do everything we can to eradicate the pathogen. Now, it has a certain attractiveness because there's been a very distinguished history of CDC and other public health entities going after pathogens very successfully, whether it's eradicating smallpox or what I was involved in was elimination of measles, which is now coming back. And just as in the military, generals always fight the last battle that they won and then try and apply the same tactics to other battles, which is a natural human tendency. Why didn't they adjust when they saw things getting worse? Well, basically what you do in infectious disease is you double down. You say, we got to go after pathogen. Pathogens trying to get back at us in some fashion. We stay the course. And it was that tenacity which has worked for tuberculosis and for measles and for smallpox and a bunch of other diseases, backfired entirely with opioids. And the reason is that no one needs a little bit of smallpox to survive. No one needs some measles to keep it functioning. But there are many circumstances, either because of pain or addiction, where people absolutely have to have opioids. And so regarding it as a pathogen that needs to be eradicated was, in a sense, where this obstinacy of an ineffective and actually backfiring intervention was just continued and continued and continued.
You're listening to Savage Minds, and we hope you're enjoying the show. Please consider subscribing. We don't accept any money from corporate or commercial sponsors, and we depend upon listeners and readers just like you. Now, back to our show. And what was the response from the CDC when the crisis level became unsustainable, when doctors or nurses were saying, we've got all these overdoses coming in our clinics and in the morgues? What was the first reaction of the CDC?
Denial. There are many situations, and maybe the current economic situations in the United States provide an analogy where people become so dedicated to a strategy that the outcome almost stops being of interest. And they just basically said, it's going to work in the future. And there's some element of plausibility to that, because basically, if you regard prescription opioids as, in essence, a starter drug, it's the entry into the situation that you're trying to cut off. There would be a lag time before the beneficial effects would show up, because it's a starter drug. And people don't overdose immediately on a starter drug. They get more and more and more, and then they finally reach levels where, overdose becomes an actual threat. So if you say that to yourself that all we're dealing with here is just an initial reaction, and we got to keep these prescription opioids as unavailable as possible, because in the usual lag time between you get the starter drug and you overdose is, say, 5 years or 7 years before you get to that level. We have to wait 5 or 7 years before we see all the wonderful effects that are going to happen. So you can, in a sense, convince yourself that you just have to stay the course until the benefits come through. And I think reading minds, because remember, I worked in eradicating diseases, so I sort of know how that tenacity approach works. And I know the people who were directing the opioid campaign. Tenacity is very important. And the notion that things will work out in the future if we just have the courage to stick with our strategy, that was, I think, very prevalent in the institutional psychology that allowed things to explode and no meaningful response was made.
One thing that you discuss in your book, and I was aware of from my own research on this years ago, was how in this millennium addiction was spreading quickly across the country, and the distribution of pills moved from the hands of primary care doctors' offices and hospitals to street corners, and then what were called pain treatment centers or pill mills. Can you discuss the rise of these pill mills and their function?
I wish I could with more factual information.
I'm thinking of your 13th chapter, Confessions of a Narc Pusher in Appalachia, where you begin with this kind of ironization that this is just 2.5 hours from the CDC. And yet Appalachia is one of the hardest hit places in the country for this epidemic.
Yeah, there are two issues to a pill mill. I use pill mill a little bit ironically in there because this was a operation which was providing the only healthcare in the Indian community. So most of what it was doing was real healthcare. However, it was also feeding a lot of prescription opioids into an addicted population and not providing any other care other than just ongoing addiction to prescription opioids. And to a great extent, that was because this was a federal operation, not run by the tribe itself. And as I describe in the book, what happened was the tribe took over the clinic and basically brought that to a halt. Now, there were subsequent consequences to just bring it to a halt, which had basically it became, just as in the United States in general, people sought illicit opioids instead. But in a sense, this was a clinic, which I was part of, in which an excessive amount of opioids were being provided in a context where no treatment for addiction was really available. So that's, in a sense, an ironic situation because it's a federal government. All this was run by the federal government. And all of it was real close to where CDC was bemoaning, overuse of opioids. So it was an ironic situation. I was working in it. Separate question of pill mills, which are described generally as operations which do nothing but give out opioids for pain or alleged pain, or basically people who are addicted claim they have pain. And their role in basically overdoses and addiction. And that's a little bit more of a complicated issue, in my opinion, at least. And the reason is pill mills exist to a great extent recently because of the draconian restrictions that have happened around provision of opioids in primary care. So these little pop-up, in effect, clinics which just give out opioids are, in a sense, a reaction to the great fear that's been created in the primary care environment to treat chronic pain or addiction. And there's an irony to the situation is that, yes, these pill mills are giving out enormous numbers of unnecessary, in a sense, opioids. However, a very good study was done, which I'm very proud of the fact that the CDC funded this study. I don't know if it knew what the outcome was going to be. No one does when you do a legit study. What was the effect of shutting down pill mills? And the effect was, if you shut down a pill mill, overdoses went up. Overdose deaths went up in the environment where the pill mill was shut down. And that also went for major drug busts by the DEA. You, in effect, had, why would that be? And the reason for pill mills is basically for addicts. They were providing safe versions of opioids, Vicodin or Percocet or equivalent. When you shut them down, the people went into the illegal market and overdosed on fentanyl. And so this business about shutting down the supply with no attention to the demand, the treatment of people, inevitably produces a paradoxical effect where the outcome of death increases. So I do want to emphasize that pill mills, from you might say, a moral standpoint, are hardly, just like the cartels, are hardly admirable environments. But they're supplying a need. And unless you address the need, any effort just to attack them is going to produce more problems than you started with.
You go into what you call the transmission interruption strategy in the third part of your book.
Yeah.
And I would like if you could discuss this a bit, because it's very related, in how the CDC began in around 2016 to control the epidemic, applying this strategy, the transmission interruption strategy, and how 6 years of their signaling the dangers ended up having a devastating failure. In a sense, they were completely ignored, during which period the opioid explosion became self-sustaining, as you maintain in your book. Could you discuss the relationship between the transmission interruption strategy and how this fed the epidemic in a way?
Yeah, the transmission interruption strategy is a basic infectious disease. What you do is you try and find where the pathogen is trying to jump from one person to the next, and you try and stop it at that point. And so, for instance, in Ebola, I'll just give you Ebola as an example. Uh, the key element that was discovered in order to control Ebola in West Africa was discovering that the transmission was taking place apparently in the funeral practices where there was everyone got together and washed the body of the person who had died. Well, that provided much comfort from a familial standpoint, but in a context where someone had died of Ebola, it was an extremely efficient method for having a whole bunch more people get Ebola. And so a key element of the Ebola control strategy there, and it was difficult to do, was to convince people that they really shouldn't be having group washing of the corpse of someone who died, particularly if they died of Ebola or hemorrhagic fever. So that would be there are a number of other instances, for instance, for polio eradication. Polio generally transmits seasonally. So when you have a surge, usually of polio in the summer, I'm just giving some examples, but it's at a low point in the winter. That means it's having harder time transmitting. So you do all your vaccination strategy in the winter to prevent it from leaping into the next season. So there are a variety of either on a individual basis or a public health basis, you go after the pathogen that's most vulnerable state. The notion behind prescription restrictions were, it's very hard to control the illegals, the cartels, but we have much more effective control over the physicians and the pharmacies, and frequently it became the pharmacies. Matter of fact, the pharmacies often and the insurance companies became the most effective restrictor of licit opioids, because no matter what the doctor prescribed, if the pharmacy was basically forbidden to give out more than a certain amount or give out whatever, the patient never got it. And ditto if the insurance company basically created a policy where people couldn't get it. So one of the things that was so remarkable about the CDC draconian recommendations were most recommendations of CDC, and I've written them, everybody ignores. You should get more exercise. You should eat better food. You should do all those things. Everybody just, ho hum and they, gather dust somewhere. The thing that was so interesting about the opioid draconian recommendations were they were just implemented astoundingly fast to the point where the level of people with cancer who were allowed to get opioids was cut in half. There's people with cancer. It's just remarkable. And part of that is not only the institutional psychology of pathogen interruption, but there's what I discuss a little bit in the book, is this Puritanism pornography duality about how we regard opioids. Is they're either, intolerably seductive things that if you take your first pill, you're, a dead man. At the same time, we have this, oh, it's so wonderful to be floating on this thing, medication. So one of the reasons it got adopted was there was this Puritan backlash, in a sense, against opioids, where we'd previously had sort of wide open. Suddenly they became, the evil um, Darth Vader of medications.
It's interesting because as I read your book, I kept thinking about the kind of discourse around pain control and how it changes from country to country.
Hmm.
For instance, when I was going into my boat in central London, I slipped one day, broke
Huh.
a rib,
Ooh.
very painful. And they gave me, I don't remember at the time, but I remember when they gave me the prescription for the pain medicine, they said, well, we can't give you more than seven. Like we're doling them out very tightly. It hadn't, they said that there was an opioid type drug that they were giving me. I do not remember what it was because I never take medicine and I actually had to. It was so painful. I tried not to. It was so painful, a broken rib or two. They couldn't tell me if it was one or two or three because they said it won't show up on the x ray, was what I was told. So I did that for a week. And when those seven were over, I had to go to my GP and get another prescription. It was extremely painful because, again, I'm one of those people, I'm very stubborn about not taking medicine. And of course, as a migraine sufferer, I've had to. But I was also aware as a migraine sufferer, the deficits of taking something like what was called nystatin or any kind of more serious migraine medicine. So I would shy away from it. I had to be really full on to take anything. I have to wonder, though, the differences culturally between how they are prescribed. And at that, although your book focuses on the crisis in the United States, we don't see this kind of crisis in any other country. What's prescribed, let's say from Germany to Italy to the UK to the US, and why the restrictions are tighter. And then the follow up question is basically, why did this happen in the States? And I view this as an anthropological problem on top of a capitalist problem, because I can answer my own question. I think a huge reason why this has happened in the States and not as much north of the border is simply because of socialized medicine.
Well, I think you're putting your finger on it, Julian, that this is much more or much better examined from a anthropologic than from a medical standpoint, because we have plenty of medications like opioids, which have what we call a narrow therapeutic window, where there's a benefit and then there's a danger to them, and you have to manage them carefully. And there are plenty of meds that fall into that category, like opioids. Why have opioids sort of escaped a rational approach to the situation and gone into these um, whiplash situations where they're either totally evil or totally good, and we go back and forth between them? And there's an instructive study that was done about surgery. And it turned out that when they compared Europe, and of course, Europe is a diverse uh, population, but let's just say Europe and the United States, in this case, it's um, basically for the same operation, you assume there'd be the same discomfort at the end of the operation. 5% of Europeans were getting opioids. 80% of American patients were getting opioids for the same operation. Now, this is back in the earlier of the 90s, late 90s and early 2000s. Well, that's an extreme difference. I don't think it's because the Europeans are, so much tougher than the Americans. I think maybe they are, but not quite that extreme. The other thing that was interesting is that in the same study, they looked at patients after operations who got opioids, and it turned out that a very high proportion, like 60% of Americans after an operation who reported no pain still got opioids.
Hmm.
Uh, And so there's definitely, and this is back, 20 years ago, there's definitely a different approach in medical practice. But I think it was a different approach along the lines of some extent what you're talking about of a cultural practice. And Americans are hedonists in the sense that, we like immediate gratification and we hate immediate pain. And we are very permissive, and then we go completely hog wild the other direction when we see the adverse effects of that permissiveness. And that's basically what's happened and why we have the highest incarceration rate in the world. Though I guess El Salvador is starting to beat us.
Well, yeah, that whole debacle with our government deporting people to basically El Salvador is now our gulag. It raises all sorts of questions, even outside of this debate, uh, as to why we're outsourcing prisons. Because you know what happened in the States when they were sending kids, juvenile delinquents is what they are called, to prisons, and then finding out that the judge were getting kickbacks from these rehabilitation facilities, right? So now it's very frightening what's going on with El Salvador, uh, drug addict or not, or however you want to call that person. Because I think, as you mentioned at the very beginning, this whole terminology of drug addict or person afflicted by a dependence, which is how the latest language has headed. I think we need to rethink how we treat these people. But then, as we're talking right now, the base of it, for instance, when I fell in the boat, if I had gone to a doctor in the States, how many weeks of painkillers would I have been given, do you think?
Well, it depends on whether you broke your ribs, three ribs, and in the Sackler era or the current era. So much would depend on those things.
Well, in the Sackler era, for instance, what?
Oh, you would have been on for the rest of your life.
Yeah, yeah. And
Uh,
now, what are the restrictions now? What can a doctor practically prescribe if I were to break ribs?
well, let me draw a distinction in some ways. It is not that difficult these days to get say, a 3-day supply of Vicodin or Percocet. The where the restrictions really come in is for higher doses or longer duration of treatment. And you say, well, that's reasonable. It is reasonable in many ways because those are much more risky environments. The higher the dose and the longer you get something, opioids, the more likely, a number of studies have shown that more likely you are to be on opioids much, much later, say a year later. And that's a little bit easier to examine than the question of addiction, because addiction has a whole bunch of complicated consequences or definitional elements, at least. Um, there has to be the notion that you don't need it for medical reasons. You're only because you have a dependence on the drug, that there are adverse consequences in your life, many of which arise from the illegality rather than from so it's a circular reasoning. But if you merely ask the question, if what gives someone a risk factor for being on long-term opioids, and a strong risk factor for being on long-term opioids is if when you initiate your initiated opioid treatment, you get high doses and you're on for a long time, meaning longer than a month or something like that, longer than 30 days. So if your question is, would you have trouble for your ribs getting a 7-day supply in the United States for opioids? I don't think so. I don't think you have a lot of trouble. Where the trouble comes in, where the pharmacies kick in, the insurance companies kick in, and a lot of the fear that the doctors experience kick in, is completely different. If you had cancer of the ribs and it was causing an equivalent amount of pain, and it was going to take some time for you to be cured of that, or you're not going to be cured and you're going to have to live with it until you die, then you're going to be in deep trouble getting opioids to control the pain. And it's paradoxical, isn't it? Because the people you would most think should be uh, have free access to pain control, the hospice type situation, those are the situations where you have the most difficulty getting opioid treatment.
Well, that's where my mind was heading. I was thinking about the difference between short term pain relief, even lighter substances than opioids, and then obviously end of life pain relief,
Yeah.
at which point, okay, throw, anything in, because if someone's suffering, there is absolutely no need to worry about, let's say, the negative factors in using X medication for more than 5 days or something like that. No?
No, exactly right. Most people, if you ask them the question, should somebody who's dying be provided with some pain relief? Most, oh, absolutely. And they wouldn't say, well, we want to stop them from becoming an addict, even though his lifespan is anticipated to be a couple months. That wouldn't be the primary thing. So most people would ask, if you ask that question, you'd say, no, 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 it should be. The difficulty is that the restrictions that are placed on longer term opioid thing make no distinction between the person who is taking them unnecessarily and the person who is absolutely has to have them. So there's been an enormous cutback on the amount of medications that people who have cancer or chronic pain for a variety, they had terrible injuries or whatever. And they're the people who are really suffering the victims of it. It's estimated there are about 17 million people in the United States out of 330 or 340 million people who have chronic pain to the point where they're unable to function in either a productive or what most people regard as a useful fashion around the home. And they have the most difficulty getting pain relief. The difficulty to some extent is a little bit of confusion over outcomes. I'm a public health guy, and I've done a bunch of clinical medicine, but my orientation is public health. And when you're in public health, the primary thing you look at is death rates. You say, we don't want people dying. And when you look at a death rate, and basically is 1 million people in the first 2 decades of the 20th century, with a apparent it's going to speed up, and another 10 to 12 years, we're going to have another million people overdosing, where it's the number one killer of adults between 15 and 25. You say, we got something, we got to bring those overdoses under control somehow. We got to do something about it. And there is basically no real strategy to deal with that. And I would propose a strategy, but I would like, if I were in charge, to think that I was capable of doing a little better than the folks who just implemented the CDC regs. That would constantly monitor the results and see if I was making any inroads. What would be the first thing you do if you have a mass poisoning? Remember, when you're talking about 1 million people dying, we're almost at Holocaust levels. I don't want to trivialize the Holocaust by implying similarity, but we're talking about 1 million people dying. and the number one killer of adults, it seems like a serious matter. What would be the first thing? It's a mass poisoning. It's a mass poisoning. What would be the first thing you do in the mass poisoning? You get the antidote, and we have an antidote available in equal accessibility to the poison. You have basically Narcan in everybody's drug cabinet, and certainly targeted to the people most likely to have it. That'd be the number one thing you do. Number two, the thing to keep in mind is that in public health, you target interventions to the people who need it most. And the irony in the situation of these draconian prescription meds is the most representative person who gets longer term opioids is a 60-year-old woman who has rheumatic arthritic conditions. The most representative person who dies of an overdose is a 30-year-old male who either shoots up or takes an excess amount of an illicit opioid. So you immediately have to ask the question, what am I doing by stopping grandma from getting her arthritis meds to prevent her grandson from taking too much fentanyl? And the answer is you haven't done a thing. So the first thing you have to do to try and prevent, in a sense, the normalization of illegality, which happened during Prohibition, is happening now, is you take the 17 million people who have a legitimate need for opioids to control pain, for either because they're dying or because they have a chronic condition, and not force them to have the cartels as their pharmacist. You make prescription opioids to people who need it accessible for them. The next thing you do is you don't have the rules around opioids made by bureaucrats or drug companies or police. You have the rules around opioid prescriptions made by professional organizations which work with opioids and have some expertise. And we don't have it. We have basically the DEA making rules around who should and who shouldn't get pain medication. They're not the people who should be doing it. The final thing is that if you really want to do something about cartel profits, and everybody has decided that it's the cartels that are the problem, not our failure to treat. If you really want to knock a hole in cartel profits, you take the 3 million or so people who are addicted and you get them into treatment. That'll knock a hole in the cartel profits. And you save a whole bunch of money of them incarceration too. You have a double whammy. You hurt the cartels and you reduce the amount of costs that are associated with incarceration. And the final thing, and this brings it to current politics, but there's the Division of Overdose Prevention at CDC, which I have freely criticized how they've approached things, is absolutely necessary for us. And the reason is they're the ones who monitor the situation. Well, guess what? They're in a dire threat to be eliminated completely under the current administration. They may have made mistakes in the past, but we can't unilaterally disarm in the face of the major killer of adults. And so CDC's Division of Overdose Prevention is our radar system, and they need to be strengthened, not eliminated. So that's my response to the current situation. I would hope that I would be, if I were in charge, somewhat more empirical. I have, quote, a beautiful strategy. But I would like to think that, unlike the folks who implemented the past CDC strategy, I would consult the results and see if what I was doing was working, and adapt if it wasn't, certainly if it's getting worse, and continue if it was working.